Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristin Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. Oh my gosh, I had to get back on the podcast today because I am so excited to have new guidelines about how to treat GSM or Genitourinary Syndrome of Menopause. If you're watching me today, I've got my glasses on because I got to read through these. I want to go through them with you because I want all patients and providers to know about this. It is so exciting and uncommon to get new guidelines. They don't happen all the time. They usually happen every so many years or even so many decades. Some guidelines are old. They never get updated. This is the way we treat something and we haven't looked at it in a long time. So most medical guidelines will go through the scope of the problem, and then they'll give providers maybe first-line treatments, and then if they fail, second-line treatments, and then if they fail, third-line treatments. And that's, of course, very helpful because it lets providers walk through a stepwise treatment of a specific problem. But the guidelines for GSM or Genitourinary Syndrome of Menopause do not give first, second, third-line therapies like that. The whole document is all about shared decision-making. And if you don't know what that is, it is a great way to practice medicine. It's where your provider talks to you about what the data shows about your particular condition, gives you the risks and benefits, and then you and your provider together will come up with what is best for you as a patient. I will tell you that I love shared decision-making. I love bringing my patients into the conversation and hearing from them what is important to them. Because remember, I practice urogynecology. Almost everything I do is a quality of life issue. For most women, if you have pelvic organ prolapse, you are not going to die from your prolapse. But your quality of life may be decreased if you can't do the activities you want to do, lift your grandkids, lift in the gym, walk, if you have to adjust yourself every time you sit down. Those are bothersome, annoying things that decrease your quality of life, but nobody dies from those things. So all the time, I have to engage in shared decision-making with my patients if we're trying to decide, for example, do we want to do surgery for your prolapse? I tell every single patient the same thing. Only you as a patient can answer this question. Here are the risks and benefits. With surgery, there's always a small amount of risk. There's recovery that goes into it. And long-term, there's a small risk of recurrence. But the benefit is you don't have to deal with the prolapse anymore. You can feel stronger. You can get back to your normal activities. How risk averse are you? Are you willing to take on that risk of surgery and recovery to get the benefit? Or are you a patient who says, I am very risk averse. I don't want any risk of surgery, so I'm going to decline that option, and I'm going to try something non-surgical like a pessary or some other exercises. That is completely within your ability to make that choice as a patient. And now treating GSM is no different. Over half our population is women. That means if they live to be 45 to 50 or beyond, all of those women will enter menopause, and a huge majority of them, some studies show up to 82%, will experience symptoms of Genitourinary Syndrome of Menopause. So let's take a step back, though, before we get into the guidelines and find out why this document was so necessary. And the main reason is that anytime I prescribe something for GSM, which is most commonly vaginal estrogen cream or some other form of local vaginal estrogen, I will talk to my patients about it, go through the safety data, prescribe it, they get home, they open their package, and they read the package insert. Oh, and then all of this false information comes crashing down on them. Can you actually believe that the package insert for vaginal estrogen and other vaginal products is false? The information that they give in that package insert stating that estradiol is associated with things like stroke and blood clot and cancer risk do not apply to vaginal estrogen. GYNs have known this for years. There's actually an advocacy group going on trying to petition the FDA to change the labeling. But it gives patients inappropriate fear of using these medications. So sitting in front of me, talking to me, they say, great, this sounds like a fabulous medicine. I want to proceed with it. And then they get home, they read this false package insert, and they never even start the medication because they don't get a chance to discuss that package insert with me. And why is the labeling for vaginal estradiol a false labeling? It's simply because the FDA has a rule that if any product contains the same active ingredient, then the package insert has to be the same in every one of those products, even if those risks have not been proven in a certain route of delivery, like vaginal use for estrogen. So I get the feeling behind that. They want to make sure that if they have data on one particular ingredient, that that data gets out to the public for every time that ingredient is used. But really, that is not the way science works. When we put certain ingredients in our mouth, they may work differently than if we put them on our skin or in our vagina or under our tongue and all these different ways that we can get products into our body. So the package insert should really be more specific to each product, but that's not how it is right now. So the package insert for vaginal estrogen is false. So let's dive into these new recommendations because I'm so excited about them. These were produced by the American Urologic Association, the AUA, the Society of Urodynamics, Female Pelvic Medicine and Urogenital Reconstruction, the SUFU or SUFU, and AUGS, which is the American Urogynecologic Association, but they're also endorsed by ISHWISH and the Menopause Society. This group started in 2022, so it took them several years to look at all the data and come together and debate and go back and forth and finally come out with these new guidelines. And the guidelines are individually numbered. All clinicians can read them, and they're really easy to read. The first guideline is right at the top that clinicians and patients should engage in shared decision making. And as I said, that means that you and your provider work together to make a healthcare decision that aligns with your goals as a patient while looking at the data and using evidence-based medicine. So we don't just want you out there making some wacky decision because you don't have all the data. It's providing you with all the data as a patient, and then you as a patient weighing the risks and balances, seeing what is going to fit best for your life, what is most important in your life. The next guideline is that clinicians should screen patients who are at risk for or presenting with signs of GSM, and people who have GSM should undergo an examination for it. So this is where I'm going to repeat again, up to 80% of women are going to experience GSM associated symptoms. And most of the time they occur at perimenopause time, so say the late 40s into the 50s and beyond. They can persist as long as we are in menopause. But even some younger women are at risk for GSM symptoms. Those might be women who have premature ovarian failure or are taking birth control pills or are breastfeeding. Did you know that breastfeeding is a condition where your estrogen level is essentially zero? So you can have mimicking of all the menopausal symptoms. Other patients may have gone through chemotherapy and their ovaries have died from it, or even had their ovaries removed at the time of surgery. So what are these symptoms of GSM? Well, the symptomatology is huge, but it relates to vaginal dryness, vaginal irritation, discomfort and burning of the vagina, the vulva, the introitus, that's the opening of the vagina, sometimes stenosis or tightening of the opening of the vagina, making it difficult to have penetration or pain with penetration. Sometimes bleeding and cracking of the tissue that causes little bits of spotting and bleeding, fissuring during intercourse, little cracks that appear during intercourse, and it makes you feel like you've got ground glass in the vagina. What a fabulous description, because that's exactly how women feel and how horrible that is. And clinicians should go through a detailed way to examine patients for symptoms of GSM. And actually, the guidelines, if you're a clinician listening, the guidelines go through a very detailed and systematic way you can do the examination for GSM. So if you need a refresher on that, please look at that part of the guideline. But GSM is not just about vulvovaginal symptoms, it's also about bladder symptoms. And that's why GSM is so prevalent in my practice, my urogynecology practice, because all of my patients have bladder symptoms. And low levels of estrogen at the level of the bladder cause things like urinary urgency, frequency, making you feel like you always need to go to the bathroom, even though you just went, irritation while you're urinating, that feeling of a UTI, even though you don't have a UTI. That's something I very commonly hear. Patients will say they have burning with urination, but they're constantly being tested by their PCP and there's no urinary tract infection. We need to start thinking of that symptom in the context of GSM and low estrogen at the level of the bladder. And that's why the next guideline says that clinicians should educate patients with GSM about what the genitourinary signs and symptoms are, and that they result from decreased sex hormones at this level. The guideline specifically says that decreased estrogens and androgens, that's DHEA, testosterone, and dihydrotestosterone, low levels of all of those hormones result in GSM symptoms. Wow, this is the first time I have ever heard androgens included in any guidelines for women for anything. So huge kudos to these researchers who are actually including the fact that low androgens, low testosterone and its counterparts, give patients negative symptoms at the bladder and vagina. And once again, if you're a clinician listening, the guidelines now go through a basic endocrine lesson of how androgens are converted into estrogens in case you need a review. Mostly we go through that in med school, but if you're not practicing hormones, you may forget about that. You may need to refresh that in your mind. But it's also helpful to let patients know that we don't need to measure or document your hormone levels in order to treat symptoms of GSM. Now, this particular part of the guideline does not apply to hormone replacement therapy in general. When we're talking about systemic hormone replacement therapy or whole body hormone replacement therapy, I feel that it is helpful to monitor levels as we go forward. But if we're just treating local vaginal and bladder symptoms, it is not necessary to measure or document hormone levels. Next, the guidelines talk about in patients who have a history of a psychosocial or sexual health concerns, maybe a history of trauma. They talk about referral to a credentialed therapist, and they also talk about possibly referring your patient to a pelvic floor specialist. So here the researchers are taking a look and saying, we know that not all of the symptoms of GSM are going to be treated just by local hormone therapy. There might be tight muscles, there might be other psychosocial conditions or history of trauma that have to be addressed. So it's looking at GSM in the context of everything that's happening in a woman's life so that we make sure that we get the best treatment for it. So now we get into the part of the guidelines where they actually start to talk about treatment. And remember, I told you we're not going to have these first line, second line, third line therapies and treatment. It's all about shared decision making. But the first guideline that addresses treatment says that clinicians should offer the option of low dose vaginal estrogen to patients with GSM to improve their symptoms. And this is a strong level of recommendation. Vaginal estrogen local therapy comes in the form of creams, tablets, inserts, little pills that you insert, or vaginal rings. And they specifically say that there is no increase in serum estradiol levels using these local low-dose vaginal estrogen therapies. And there is also no increased risk of endometrial hyperplasia or cancer. This is one of the important things when we're giving whole body estrogen. We have to make sure that if you have a uterus, you always receive a whole body or systemic progesterone, and that's to protect your uterus against the risk of hyperplasia, which is tissue overgrowth or cancer. But when you're just using local vaginal products, you do not need to necessarily add a progesterone to protect the uterus. They are safe from that point of view. Now, there are no head-to-head studies of one form of local vaginal estrogen over the other. Like there are no studies comparing vaginal estrogen cream to the ring or cream to the tablet, things like that. For vaginal dryness, this data is very strong, but the studies that they looked at were not very consistent in dosing or the regimen. And one of the challenges that they mentioned, and I think this is really astute, is that many of the studies that compared vaginal estrogen, say cream, tablet, or ring, to placebo, it wasn't really placebo, meaning using nothing. It was using a vaginal moisturizer. And we already know that some of patients' vaginal dryness is improved by using a vaginal moisturizer. So I bet the studies would show an even bigger difference and bigger improvement in vaginal dryness if they compared the vaginal estrogen products to true placebo, meaning using nothing. This is also part of the guidelines where they actually talk about testosterone for GSM. And they mention that there are a small number of trials and there were some mixed results, but the results seem to support the use of testosterone more for orgasm than GSM. But they still specifically state that clinicians may choose to offer patients, in the context of shared decision making, vaginal testosterone for the treatment of GSM. And when you look at the names of the researchers on this paper, these are really highly intelligent and highly strong names in the field of menopause medicine. They know that the vagina and the vulva and all of the tissues at that level have a high number of testosterone receptors. So, of course, replacing testosterone in that area is going to have a positive effect. If there are testosterone receptors there, we need testosterone in that area. But they were looking specifically at the data, and we just don't have a specific study looking at testosterone in the context of does it improve GSM symptoms. All right, but we're going to keep going because these guidelines, I want to get through all of them. And there's a lot of them, and I want you to make sure you hear all of them. The guidelines also recommend that clinicians can offer the option of vaginal DHEA or ospemifene in patients with GSM. So if you don't know about those two, vaginal DHEA is a little suppository that women place in the vagina nightly. And once the vaginal cells absorb it, inside the vaginal cells, they convert the DHEA into both estrogen and testosterone. So this is actually a way to give vaginal estrogen and testosterone without actually giving vaginal estrogen and testosterone. So that if any of the excess DA happens to circulate through the bloodstream, all you're going to find in the serum is DHEA, which is a natural hormone made by the adrenal gland in both men and women. Ospemifene is an oral tablet that may improve vulvovaginal dryness or painful intercourse. And some patients may like the idea of needing to take an oral tablet every day rather than putting something in the vagina or on the vagina. So that's a good option as well. And the guidelines recommend that both of those can be offered once again in the arena of shared decision making. The next guideline talks about women who are already taking systemic estrogen therapy. So they're using a patch or an oral pill or a cream or a pellet. In those patients, not all of that systemic estrogen therapy will treat GSM or vaginal and bladder symptoms. So clinicians should offer the option of low-dose vaginal estrogen or vaginal DHEA, even if you're taking systemic estrogen therapy, simply because we see it all the time where people are on systemic estrogen therapy, but their vaginal and bladder symptoms are not relieved. And I'm always educating my patients that the concentration of estrogen and testosterone receptors in the vagina and bladder is so high that it needs more estrogen than anywhere else in the body. So when you take a systemic product like a cream, a pill, or a pellet, it's going to equally divide to every organ in the body, but we need more of a concentrated dose for some women at the level of the vagina and bladder. So appropriate to add vaginal estrogen therapy to patients taking systemic, or you can choose the vaginal DHEA if you would prefer that instead. And now, two of the guidelines specifically get into the arena of urogynecology. So I was over the moon when I heard about these next two recommendations. The first one is that in patients with GSM and other genitourinary conditions like overactive bladder, clinicians may offer low-dose vaginal estrogen to improve their symptoms because we have studies that show a significant improvement in frequency, urgency, nighttime urination, and irritative voiding symptoms, bladder symptoms, when you use low-dose vaginal estrogen. The next guideline recommendation specific to urogynecology is that in patients with GSM and recurrent urinary tract infections, clinicians should also recommend low-dose vaginal estrogen to reduce the risk of future UTIs. Oh my gosh. I hope this will rock the world of some of my patients and send them into their providers and say, yes, I need vaginal estrogen. I am one of these women with recurrent UTIs. Because recurrent UTIs, I deal with patients with this constantly, and it is horrible for them. Just when they think they get over one UTI, they've got the burning and pain, it happens again, or they get a UTI that they just can't get rid of. And UTIs are not just burning and pain at the level of the vagina. In older women, they put women at risk for that bacteria getting into the bloodstream, which is called urosepsis. And women die from urosepsis. So prevention of UTIs is not just a quality of life issue. This is a health risk that needs to be improved. And the guidelines indicate a 2013 systematic review of 44 papers studying postmenopausal women with GSM and showing that local low-dose vaginal estrogen reduces the rate of recurrent UTIs. And then they looked at another multi-center retrospective review of mostly postmenopausal women. 93% of the women in these studies were postmenopausal from the Kaiser Permanente system in Southern California. And shout out to Southern California and my friends and colleagues there. But it showed again that vaginal estrogen reduced the risk of recurrent UTI. Specifically, it was a reduction of 52%. So putting on a vaginal estrogen product can cut your risk of a recurrent UTI in half. Clearly stated, clearly shown, and now reaffirmed in this particular guideline. Every woman with recurrent UTIs should be on some form of low-dose vaginal estrogen. Okay, so I'm done with the Urogyne part of our talk, but I'm getting back now into the part of the guidelines that talk about safety. The guidelines go through the absence of any evidence linking low-dose vaginal estrogen to the development of breast cancer. And this is a huge one. This is not new data, folks. This is stuff we have known for a long time. The existing data supports that low-dose vaginal estrogen does not increase breast cancer risk in women with an average risk of breast cancer. That means a risk of less than 15%. And if you don't know your personal risk of breast cancer, it is not difficult to find out. Any of your providers can do a very easy risk assessment. It takes into account your own personal history, your family history, if you've ever had a breast biopsy, and very quickly on the spot, they can give you your estimated risk, lifetime risk of breast cancer. And for a majority of women, that's going to be about 12.2, 12.5. So anything less than a 15% lifetime risk of breast cancer is considered low risk. So in that large group of women, vaginal estrogen, 100% safe. The data also suggests that low-dose vaginal estrogen does not increase the risk for recurrence of breast cancer or breast cancer mortality in women who they themselves have had breast cancer. So now we've gone to the opposite end, not the low-risk women for breast cancer, but women who've actually been treated for breast cancer. We do not see a risk of recurrence or a risk of increased mortality by using vaginal estrogen. This one is huge. I hope all of our oncologists read this part of the guideline and understand that it is safe to give breast cancer survivors vaginal estrogen because most breast cancer survivors suffer from GSM symptoms so much more significantly than non-breast cancer survivors. And that's often because they're taking estrogen blocking drugs. They do point out in the guidelines that systemic levels of estradiol may increase briefly and to a small degree after you start low-dose vaginal estrogen. So let's think about why this would happen. Before you use any vaginal estrogen, your vaginal lining is paper thin. Paper thin. So when you apply that vaginal estrogen, of course, some of it may bypass the vagina and get into the systemic blood flow. But as you continue to use vaginal estrogen, you are going to thicken up the vaginal epithelium to where it once was, where it should be. And the studies show that systemic levels of estradiol return back to normal, back to menopausal levels after 12 weeks of use. That's about how long it takes vaginal estrogen to initially rebuild the vaginal epithelium. 12 weeks. So while there might be a slight bump in the first several weeks, it goes back down to zero after 12 weeks. And then if you continue to use vaginal estrogen long-term, we don't expect to see another bump in the serum estradiol because now your vaginal tissues are staying thick and flexible and healthy. So the guidelines clearly state for patients with GSM and a personal history of breast cancer, clinicians may recommend low-dose vaginal estrogen in the context of shared decision-making. So this is really exciting. It's once again stating what we've known for years and what I have been telling my patients for years. This is safe. This is effective. This is not increasing your risk of future breast cancer or mortality from your breast cancer. It goes on to say that also the products, the vaginal DHEA and the ospemifene, also do not increase the risk for breast cancer. So those are other options you can use as well. It restates that low-dose vaginal estrogen does not increase your risk for endometrial hyperplasia or cancer. That's why we don't need to use a progesterone with it. And once again, neither does the DHEA or the ospemifene, which is marketed under the name Osphena. That's the oral tablet that you can take. And at the end of the guidelines, they recommend that clinicians should counsel patients that therapy for GSM is long-term treatment and follow-up may be required. So this is something when I start a vaginal estrogen for patients and they're a little bit hesitant, but we talk about it and through shared decision-making, we decide this is a good option for them. Very often the next question they ask is, how long am I going to use it? And I say, well, how long do you want to be alive? Use it for the remainder of your life. Think about treating your vaginal estrogen or with your vaginal DHEA or your ospemifene like brushing your teeth. How long are you going to brush your teeth? Probably until the day you die. How long are you going to wash your face? How long are you going to bathe? How long are you going to put on your vaginal estrogen? These are just things that we are going to maintain for the remainder of our lives. So from one person, thank you to all of the hard work that this particular group did. Thank you to all the groups who have endorsed it. I want to share this with everybody, patients and clinicians alike. I think there's so much good information in these guidelines. As I said, for people who are already menopause providers, none of this is new information. This is just a great day to celebrate. These guidelines just came out in 2025, and I wanted to make sure that you guys heard about them from me. Talk to you next time. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.